Good evening and welcome to Conversations Live, Understanding Dementia. I'm Patty Satalia. The statistics surrounding dementia are sobering. If you don't currently know someone with memory impairment, a family member, friend, neighbor, or coworker, then you most certainly will know someone in the near future. More than 5.5 million Americans have Alzheimer's disease, with millions more suffering from other forms of dementia. Tonight, our guests will provide facts and information about Alzheimer's, from symptoms and diagnosis to caring with someone with the neurological disorder. They'll also take your questions. Our toll-free number is 1-800-543-8242, and our email address is connect@wpsu.org. If you'd like to join us on Twitter, you can tweet a question to @WPSU. Now let's meet our guests. Dr. Eugene Marsh is the Senior Associate Dean for the University Park Regional Campus of Penn State College of Medicine. He's also a practicing neurologist and Associate Director of Penn State Hershey Medical Group in State College. Cindy Keith is an RN, certified dementia professional, lecturer, and the author of 2 books on dementia care. She travels throughout the country to provide workshops and seminars for those who work or live with dementia and Alzheimer's patients. She also counsels families and trains medical professional staffs to deal with the challenging behaviors of dementia patients. Thank you both so much for joining us.
You're welcome.
Up to 25% of people over the age of 75 and 40% of people older than 80 have some form of dementia. Let me begin with you, Dr. Marsh. What exactly is dementia? What happens in the brain to cause symptoms of dementia?
Patty, dementia is really a combination of problems. It's primarily defined by a loss of memory. That's what most people associate with the word dementia. But typically, it's also associated with other abnormalities of what we refer to as a higher cognitive function, which would mean higher brain functions, like language, the ability to do complex tasks, the ability to keep oneself oriented in space, things such as that, executive function, the ability to reason, things like that. So, but the common denominator in all forms of dementia is memory loss. And it always, it's a gradual process. That's another part of the definition. It comes on gradually, and it's progressive over time.
And so what happens to the brain in, for example, Alzheimer's disease, which affects 60% of those who suffer from dementia?
We know a lot about what the brain looks like from studies that have been done. And what we find are the brain cells, the cells in areas that are particularly important to forming new memories, recalling recent memories, sometimes language function. Those particular areas of the brain, the cells, are found to have a damage. And this damage consists primarily of protein deposits, abnormal deposits of protein. Exactly why that happens is something that is not clearly understood. Therefore, how to prevent it is a huge challenge. But there are changes in the nerve cells themselves that cause them to stop working and therefore affect memory.
All of us have moments of forgetfulness. We can't remember where we put the car keys. We don't remember where we parked the car. When, Cindy Keith, is that forgetfulness cause for concern?
It's not so much that you can't remember where you parked the car or where the car keys are. It's when you have the car keys in your hand and you can't remember what to do with them, or you find them in the freezer, or you drive to go to the grocery store and you end up in the next town and can't remember why you went there. It's that kind of a memory problem. But if you feel you have a memory problem that you're concerned it could be dementia, you should get it checked.
You said earlier, Dr. Marsh, you talked about proteins in the brain that affect how nerves in the brain function. All of this are things that we see on autopsy. So if someone suspects that they or someone they love has dementia or Alzheimer's disease, what tests would be recommended? How would you test for it?
Well, it's a very good question, and the diagnosis is made by a combination of taking a good history, listening both to the patient, to the family, as many people as you can gather around to talk about what they've seen. That's really the most important thing. The exam, and particularly the neurological exam, can be helpful in confirming but also ruling out other things that could look like Alzheimer's but actually be caused by something that would be treated and managed much differently.
For instance, you may have symptoms that seem like Alzheimer's, but it could be a vitamin B12 deficiency or hypothyroidism, for example.
Exactly.
That could affect memory.
Yes. And those are the tests that we typically do. Those lab tests that you mentioned, and also an imaging study of the brain, which would be an MRI would be most helpful, but CAT scan would be another one, to make sure that there are not any structural abnormalities that could be causing the memory problem. So most of our tests are used to rule out other causes, and then once that is done, if everything fits with what we typically see in Alzheimer's disease, then that becomes our diagnosis, our working diagnosis. A biopsy obviously is not a good way to go, and so we end up, after excluding other things, going with what we call a diagnosis of exclusion when the clinical pattern fits and the memory pattern fits.
And so we know it's not hypothyroidism.
Yeah.
We've tested that out and it's come back negative. Tell us a little bit about this test, because I think a lot of people worry about Alzheimer's. Sometimes they're worrying needlessly. Other times, their judgment of how much they're missing is off. They're underestimating. So how important is it, Cindy, that someone who fears a dementia go to this appointment, this testing, with a family member, someone who really knows them?
Exactly. That's key. They should have someone there with them. It is very important that if it's bothering them, if they're truly worried about it, that they should get it checked out. The best thing that can happen is the doctor does all of those exclusionary tests and says, oh, well, you have a vitamin B12 deficiency, and all we have to do is give you shots and you're fine. So, or too much stress in your life, and that's, we're all kind of going ahead full steam and have a lot of stress in our lives, so that's often part of it. And
even a urinary tract infection among the elderly can cause symptoms that seem like dementia. Yeah, yeah. So it's very important that they should get that. If it's bothering them, get it checked out. So this is, it's called the mini mental state test, and there's a score of 0 to 30. Anything under 25 is an indication of impairment. Dr. Marsh, if this test is conducted and someone scores in the low 20s, do you tell the patient?
Oh. It varies, and it depends on the patient. Sometimes you can tell during the process that it's okay to go ahead and start discussing that. Sometimes, for instance, if it just happens to come up, oh, by the way, Mom's been having some trouble with her memory. We do the test, we find that. I would say something like, yeah, it does look like that could be the problem. Let's look into that a little bit more, and not jump right into what I might think the diagnosis is. It will come up in their discussions at home, but I try to be careful and sensitive to what I feel like the patient and that family is ready to discuss, and sometimes it's a second visit after we've done the testing, reassuring them that we've looked for other things, and then starting to talk about that. But it does vary a lot according to the patient and the family.
The testing, we should probably point out, includes things as simple as count back from 100, or name animal. How many animals can you name in 1 minute? A very important test, and one that is sometimes more indicative of an early dementia is than the mini-mental, is the clock drawing test. Have you found that, Dr. Marsh? Yeah. The clock drawing test is very important. You can have someone who's having a pretty good day, and they can score fairly high on the mini-mental, yet not be able to draw an appropriate clock face with the time that you've asked for, because it calls on different areas of the brain to figure all that out. It's fascinating to see some of the clocks that these people draw. Go ahead.
The other testing I would mention as well, the mini mental status exam is not terribly sensitive. A lot of people can have problems and still score very well, particularly people who have been forming at a very high level, and they've noticed a change, families noticed a change, but they'll still score a 30 or upper 20s. But you can do some additional tests, like Cindy mentioned, or detailed neuropsychological testing, which is usually done by a neuropsychologist, which is much more detailed testing that may last for an hour or two or longer, to delve into the details of the memory problem, what parts of the brain seem to be affected, and also test for depression, anxiety, and those types of things. As Cindy alluded to, depression can cause a presentation very much like Alzheimer's disease, usually not as severe, but we refer to it as pseudo-dementia because it looks like dementia, but it's actually from somebody who has depression or some combination of problems in that area. The good news is that it's much more treatable than Alzheimer's disease, and so we always try to look for that.
And of course, the real benefit to early diagnosis is that the person with the disorder has some chance to be involved in the decision-making around that. And I'm going to follow up on that in a moment, but first take a couple of phone calls that have just come in. We've got Bernie who's calling us from Clearfield. Bernie, you're on the air. What's your question, please?
I just had a comment that my mother lives in a personal care home now, and her dementia is she's very lucid in the moment. And so people that don't know her, like when she goes into the hospital, they don't really recognize her as having dementia because she can carry on a perfectly normal conversation. But 5 minutes later, she doesn't know who you are. And so sometimes they feel like the family belongs in the personal care home. However, she did do what the nurse had said in the beginning. She drove to another town and, progressively did not take care of herself and that type of thing. And we couldn't even get her out of the house at all. And was unable to care for herself, not take her medicine, that kind of thing. But the one nurse that had come to her home for a long time had said to me, I kept telling her, you have to write everything down. She doesn't remember anything, etc. And then she told me, I saw your mom one day at Walmart. She didn't have a clue who I was. And I said, that doesn't shock me. I told you she doesn't remember anything. And that was just a comment that I wanted to make, that just because somebody's very lucid in the moment doesn't mean that they don't remember. She's okay at breakfast, but at lunchtime she can't tell you what she had for breakfast.
Right. That's an interesting point, Bernie. In fact, in your book, Cindy, you point out that there are moments when the clouds move and people even in advanced stages of Alzheimer's seem very, very lucid.
Yes, and Bernie, you should really just enjoy this time with her in this state because you can share many, many moments with her and create a lot of good memories for yourself at this stage, even though she will forget them.
That's a good point. And attitude and the way we approach some of the situations, you say how important it is to maintain a sense of humor.
Yes, definitely. Definitely. We all need to maintain that sense of humor. And people with dementia often maintain that sense of humor for a long time. And that's great to see. I love to put smiles on their faces. So any time you can put a smile on their face, you're also putting a smile on their heart.
All right. We go to Karen, who's calling us from Altoona. Go ahead, please, Karen.
Hi, and thank you for the show. This really helps me in a lot of ways. I just have a question that I think a lot of viewers are probably having too. Can you please explain the difference between Alzheimer's and dementia? Because you're using the two kind of, in the same perspective, but there must be some kind of difference. Could you explain on that, please?
Thank you for asking that, because there is a difference. Alzheimer's is one form of dementia. Tell us a little bit more about that, Dr. Marsh.
That's exactly right. Dementia is a rather broad term that would apply to anyone that would have memory problems and some of the other things. Alzheimer's would be a subgroup of that. It happens to be the most common cause of dementia, but there are other causes of dementia as well. So dementia would be the broad category of memory problem, and then Alzheimer's would be the most common cause of dementia. And there are other causes of dementia as well.
Stroke, for example.
Multiple strokes, the small strokes that we often see on MRI, B12 deficiency, thyroid disease, things that can go on structurally in the brain, such as brain tumors and enlargement of the ventricles and things like that. So all of those together, any of those can cause dementia, but Alzheimer's would be the most common cause.
Tell us a little bit about the stages of Alzheimer's, because we refer to the Alzheimer's as progressing in 3 stages.
Well, the experts don't really agree on what scale to use. Like the Alzheimer's Association has 7 stages in their scale. And the first stage is no impairment, so by that definition, we're all in the first stage already. But I like to tell people that I'm speaking to and family members not to get so hung up on what stage is my loved one in right now. Why are you trying to put a label on it? It doesn't help them, and it doesn't really help you. It might help a researcher to know a stage, but if you must put a label on it, something simple like early stage, middle stage, and severe stage, to keep it simple. In the early stages, you start to notice some forgetfulness. Your family will begin to notice things. The doctor may be able to pick it up at that stage with the appropriate testing. And the person definitely is afraid. They're terrified that it could be Alzheimer's or some other kind of dementia. So it's a really difficult stage because that person knows there's something wrong. And then as they move into the middle stages or moderate dementia, the forgetfulness is much more pronounced. They really should not be living alone at this stage because they're not safe. This is when they might leave the burner on the stove, or they might leave the house and end up, in another town or something. And they have much more difficulty and probably can't adequately handle their finances in this stage. So that's becomes a real issue with many families. And then as it progresses even more into the severe stages, they can be wandering. You can see agitation, some paranoia going on. If they're still walking, they're going to be falling because the brain is forgetting how to walk, and the brain eventually forgets how to swallow, and they will often get an aspiration pneumonia from choking on food or fluids.
In fact, it's dehydration and malnutrition and falls that really are the complications that
Yes.
lead to death
Yes.
Among Alzheimer's patients.
Yes.
Let's real quickly reintroduce our guests. If you're just joining us, I'm Patty Satalia, and this is Conversations Live, Understanding Dementia on WPSU TV and WPSU FM. Our guests are Dr. Eugene Marsh, the Senior Associate Dean for the University Park Regional Campus of Penn State College of Medicine. He's also a practicing neurologist and Associate Director of Penn State Hershey Medical Group in State College. And Cindy Keith is a nurse, certified dementia professional, author, and lecturer. And our telephone number is 1-800-543-8242, and our guests are ready to take your call. You may also email your question to connect@wpsu.org, or if you'd like to join us on Twitter, you can tweet a question to @WPSU. And we've got Leon from State College on the line. You're on the air, please, Leon. Go ahead.
Hi. The nurse had made a comment about the clock test, and I wanted to relate something. My partner, who has, she went to check with a neurologist. I'm getting nervous right now. With a neurologist about Alzheimer's, or she was forgetting things. And one of the things he had her do was take 2 pentagons, put them together by one particular point, and asked her to draw that, and she did. And then he asked her to draw a clock. Now, he did not say a clock face. He said a clock. The clock on our mantle is a pentagon. and she was drawing that clock because he said a clock. And he immediately said, you've fallen back to the previous test, and you have Alzheimer's. Just blurted out that way.
Oh, my.
Didn't do anything. And she, by the way, is very jaundiced about males being sexist anyway, and she felt this was just a strict sexist type thing.
And to your knowledge, she doesn't have dementia or Alzheimer's. Is that right?
I believe one would say she has Lewy body dementia rather than Alzheimer's. And also, I can't hear what you're saying. Also, she can understand what is being said. She cannot respond quite often. She used to give lectures to parliaments and to Congress, and she can't put a sentence together anymore and makes up a lot of words.
Yeah, thank you. Do you have a question?
How do I get her to talk? She won't talk. She won't even shake her head anymore.
But there are other ways to communicate, and you talk about that beautifully in your book.
There are. Does she sing? Was there music that she really enjoyed, Leon?
Beg pardon?
Was there a type of music that she really enjoyed listening to or singing along with?
She doesn't sing, but we do have the radio on the classical station all the time.
Okay. Drawing or writing, is that a possibility?
She cannot read anymore. She was a voracious reader. She had a fantastic vocabulary, and she can't put things together right now.
Is she frustrated, though, or is she calm?
I believe she is frustrated, and she's terrified. She knows what is happening.
Yeah. Well,
Dr. Marsh.
She's terrified.
I
try to calm her down. We take each day one at a time, and that's what we have to do.
Dr. Marsh.
Yeah, I really empathize with what you're describing there. I've heard other patients describe very similar things. It just seems that the things that the patient may have been just most skilled at in previous years seem to be the things that are lost, and that it's cruel. It's a very cruel disease in that sense. One thing that I have heard, and I have actually seen this, is some of the facilities that help patients with Alzheimer's disease and sort of provide some respite care during the day have found that there are other ways that patients with Alzheimer's can communicate, or Lewy body disease, any kind of dementia. One of which, in this particular patient, was art. This was a former sawmill worker who developed Alzheimer's disease and had never picked up a paintbrush in his life. And he went to one of these centers and started painting. And he communicated with his family really through his art, which was fascinating, really beautiful, colorful art. And that gave them something to talk about, and he became, it kind of helped his frustration. But there are other mechanisms too that can be used, just may not be the typical things, or may not be something that person has used in the past for communication.
And there's a lot of satisfaction on the part of the caregiver and the person with dementia when they can express themselves creatively, whether it's through art or through music. So really it's all about finding what in this person's life brought joy in the past and how, perhaps in a different way, you can make it happen in this diminished way. So not focus on the loss, but on the capability or capacity that remains.
Leon, I'd like to say that if this is frustrating for her, please avoid asking her questions that would require her to answer more than a yes or a no. Because if she sees you're getting frustrated, then she is getting even more frustrated. So if yes or no is all she can do, or shaking her head yes or no is all she can do, accept that with a smile and a hug, and don't continually be pushing her to do what she cannot do.
Good point. We go to Gina, who's calling us from Clearfield. Go ahead, please, Gina.
Yes, hi, good evening. I just was wondering if you could please differentiate between the prognosis end progression or the speed of progression in somebody who has been diagnosed with Alzheimer's in their late 50s versus an older person?
Dr. Marsh?
Typically, Alzheimer's disease can present in the 50s, and certainly there's a subtype that often will do that. More typically, we see it 60 and older. The older the patient, the higher the likelihood or the higher the prevalence. In the 50s, you often see a more aggressive form of Alzheimer's
early
disease.
onset.
Mm-hmm. And so it's you can't generalize. Everybody who presents in their 50s is not going to have a more aggressive form and a shorter lifespan, but in general, if you look at everybody across the board, then that would be the pattern that you would see. But so much depends on what that individual, how that person is presented and what their history has been over the last several years and how aggressively it's progressed during that time. That would be a better predictor.
But generally, I read, and it may not be correct because I seem to find different things in different places, but for Alzheimer's among the elderly population, the duration is 3 to 8 years, generally speaking.
Mm-hmm.
Is that safe to say?
Mm-hmm.
No.
It's hard to say sometimes because people wait so long to get the diagnosis. They're already in the later stages of the moderate stage when they get the diagnosis, and so it's really hard to say.
I think it is, but I think that's generally a range that we try to get, but it does vary, and so I don't try to lock families into that at all, because I've seen people shorter and longer, and you just don't know how one individual is going to, what their course is going to be.
I want to quickly ask you something that we talked a little bit about a moment ago, and that is an early diagnosis and this opportunity to plan for the future, to prepare for the worst, and for the person who's being diagnosed to have some role in the decision making. And one of the things I'm particularly interested in talking about is acquiring a durable healthcare power of attorney. Yeah. Can either of you comment on that, and then I'll take our next call?
Go ahead, Cindy.
I think it's crucial that as soon as that diagnosis is made, or before the diagnosis is made, to get that durable healthcare power of attorney, because people will be needing to make decisions for this person. And that's a huge step and will make everyone's life so much simpler once you get that out of the way.
And explain what it is. It's giving someone
the power to make medical decisions for that person. So when it comes time to admit them to the hospital, they can do that, even though the person may not want to go. To admit them to a facility, even though the person doesn't want to go. That healthcare power of attorney has that power.
Okay. We go to Debbie, who's calling us from Altoona. What's your question, please?
Hi. My mom just turned 86 in November, and I believe that her dementia started like 2 years ago. She does live by herself in the home. My father had a massive stroke 10 years ago, so she's in this humongous house. She won't hear of moving out at this point. She does want to go see a neurologist because that feels like she's a bad person. I tried to go to counseling a couple of years ago, and I don't need that. I'm not crazy, but it's so hard for her because I'm the only kid in town. My brother's out in Chicago, my sister's down in Maryland, and they just can't be here, in 2 hours or whatever. But I am the power of attorney for the medical. So, but she's just changed. It's almost like a bipolar, because I'm a behavior therapist, so I kind of like tagged her as being borderline because of how much she has a mood swing.
But what you're talking about sounds rather common. There are 25% of those who have some form of dementia who are living alone. Mm-hmm. A lot of risks associated with that, Dr. Marsh.
There really are, and it is a very challenging problem to deal with, not only the living arrangements, but obviously things like driving. We mentioned the power of attorney. Those things need to be taken care of. But safety is something that has to be addressed. In your mom's case, I think you mentioned that she had not been evaluated yet, that she had not been to see anyone or had not agreed to do that. I think that's really important. If she has a doctor that she trusts, a primary care doctor, can certainly do the evaluation and then refer her if needed. But she needs to have that because there are a lot of things that can look like dementia, particularly in the elderly, that are very, very treatable, and you don't want to miss those. So that would be the first thing. And the second thing, if you have her power of attorney, I think that's very important. But exercising that in a situation like this can be very difficult. There are other options. If she will not move out of the home, you can have someone come into the home.
And that's easier to do than I think a lot of people think.
It is, and there are a lot of services, a lot of people now who are trained to do that. Cindy could speak to that as well, but that can be very helpful. Then you keep your mother in the house that she loves, but that can be expensive. But it's it works very well. As things progress, I think watching out for things that may not seem obvious right now, making sure that she's not leaving the stove on, making sure she's not leaving the house unlocked, making sure that there are not rugs around that she could fall on. Common sense things that are always important to think about and look for before something happens. But I think there are other ways to solve it, but certainly convincing someone to move out of their home is one of the most challenging things.
You get a lot of phone calls about this, Cindy.
I do get a lot of families with this particular problem, and those are very good responses, Dr. Marsh. And if they won't listen to reason from you, I would consider, especially if they won't allow people to come into the home to help them, I would consider maybe a family intervention, to get all of the family together and sit her down and say, look, we love you, we want you to stay in this house, but the only way you can do it is if we get the okay from the doctor. That kind of thing.
You even talked in your book about therapeutic fibs. For example, saying to somebody, someone moved into the neighborhood and would like to talk with you about gardening, and so create what your mother may think is a friendship, but it actually is a caregiver-patient relationship.
Yeah, yeah. Therapeutic fibs, we don't call them lies, we call them therapeutic fibs. Because if your goal is to keep this loved one happy, safe, and healthy, and their short-term memory is very limited or gone, whatever you say, they're going to forget in a short time. So if you can tell them what they want to hear, give them hope that they're going to get what they want, then you've kept them safe and happy, and you can move on to the next thing that's on their mind. I don't advocate lying to people automatically. You can talk around the subject sometimes, but you have to be very careful because they will always be reading your body language, and if they sense that you are trying to think of a lie, they're going to get angry with you.
But someone may be open to establishing what they think is a new friendship.
Yes. Yes. This is a new friend of mine, and I know you've had these wonderful gardens all these years, and she wants to learn more about it. And so, is it okay?
She's going to stop over on Mondays.
Stops over, and well, then she's going to forget that she was there Monday, so she comes Tuesday too, and that sort of thing. Yeah.
One other thing that your healthcare provider, her healthcare provider, can do is sort of play the bad cop in this situation. It's not a great term, but in other words, deliver the bad news. Deliver the you're going to have to move. There's really no choice, so that the patient doesn't blame you. They may not remember it, but it's always better for them to be mad at the provider than to be mad at the family. And so it is not uncommon for us to take that role, particularly with driving. And so you go home and you then say to your mother, the doctor says you have to stop driving. It's not my choice, but this is what we have to do. And so that's another thing to consider. It doesn't have to be something that that the family has to take the whole burden for. You can always have people in the healthcare field that can help you with it.
All right, thank you for your call. We go now to Charlotte, who's calling from Du Bois. Go ahead, please, Charlotte.
My question has to do with hypothyroid. If you have that diagnosis, you're checked regularly, and your medication is adjusted as needed, does that lessen the chance of dementia occurring? And the other part of it is, your age of onset have anything to do with it?
Age of onset of the hypothyroidism?
Yes, yes.
Dr. Marsh.
Well controlled, if you have hypothyroidism and it's being treated, your risk of dementia would be no greater than someone else who did not have thyroid disease. So I want to make sure that that's clear, that the only reason we mention that is that people with unknown hypothyroid, the people who have not been diagnosed, can present with memory problems before they even know they have this. Or if they haven't been checked in a long time and the level has dropped significantly, then they may need an adjustment. But just thyroid disease by itself would not predispose or make someone more likely to have Alzheimer's disease or other forms of dementia, as long as it's treated and monitored correctly. And early onset would not really have an impact either way. That would not matter. And if it's somebody who's had thyroid disease since they were 20 or 30, as long as it's controlled and monitored, they should not worry about becoming demented.
What this does lead me to, though, is we often hear the phrase, what's good for the heart is good for the brain. So exercise and reducing stress and all kinds of things like that. Can you talk a little bit about strategies that would be good in terms of protecting your brain?
Yeah. Well, there are a lot of things that can affect the brain, as we've talked about tonight. Certainly Alzheimer's disease is the main topic, but stroke we've talked about, and there are a lot of other things. And you're exactly right. The things that help you maintain good general health will also help the brain. It's not as clear-cut as you might see in the cardiovascular system, but it does have an impact. Diet has an impact, and there's evidence that the types of things that we're all told to put in our diet, the fruits and vegetables and nuts and things like that, may be helpful, and there's some evidence that it can be. But taking good care of yourself, reducing your risk of these other things such as stroke by exercising, keeping your blood pressure controlled, keeping your diabetes under control, exercising, keeping your weight down, all of those things are important when it comes to the broad category of disease that can present as dementia.
All right. Judy is on the line from Lewistown. Go ahead, please, Judy.
Oh, thank you. Well, I have 2 aunts and 2 uncles who had dementia, who spent their last days in nursing homes. And I wondered, now, how susceptible am I? I talked with my primary care physician, and she said, well, now, those, your aunts and uncles, and they were all on my mother's side, were diabetic. So she said, maybe it's just a kind of diabetic dementia. And since I'm not diabetic, she said, don't be so concerned about it. Is that a good thing?
Isn't it more the early onset diabetes that has the genetic link?
Yeah, the early onset Alzheimer's disease would, and that is the hereditary form of Alzheimer's disease really only represents about 5%. So about a 5% risk, 5% of people would fall into that category. So that's not a very common cause. What about your mother?
No, well, my mother had multiple strokes, so she really didn't have dementia that we could tell.
Well, that would be a very good sign, since this is usually what we call autosomal dominant, so you would expect it to penetrate through all generations. But it also would support the fact that this may actually have been something other than Alzheimer's disease and may have been related to a tendency to have more strokes, which we know can cause dementia, but wouldn't represent the hereditary form of Alzheimer's disease.
All right, thank you for your phone call. We go to Judy, Jim from Windber is on the line.
Hello. My question is this. Can low oxygen levels in the blood make the symptoms of dementia worse or show up or make it look like the person has dementia?
They're both shaking their heads yes. So for the radio listeners.
No question about it. I'll speak to this, and then Cindy may want to add some more, but people who have dementia, if anything happens, whether it's low oxygen, low glucose, if it's a diabetic and have too much insulin, the glucose goes lower, abnormal electrolytes in the blood, urinary tract infection, the flu, almost anything can make the dementia worse, can make it appear to be worse. The good news is that usually that gets better, almost always gets better as you treat the underlying condition. But low oxygen could definitely make the person with dementia worse, but should get better as they have that corrected.
Cindy, anything to add?
Well, the only thing I would add to that is that if low oxygen is a problem for this person, you should try to get that addressed and find out what the underlying problem is to see if there's some way you can fix that, because they're at a very high risk for falls. When their oxygen is lower, they're more confused. They're at a very high risk for injury when that happens.
All right. I'd like to switch gears a little bit and move to the caregiver, because 70% of those with Alzheimer's disease are cared for at home by a family member or a family friend. And I'd like to talk a little bit about, Cindy, the do's and don'ts for caregivers in terms of interacting with someone with dementia.
First of all, don't argue with them. Because their reality is as real to them in that moment as yours is now sitting here listening to me. And you're going to have a really hard time convincing them of your reality versus theirs. So don't argue with them. Get out of your reality and into theirs. If they insist it's Sunday today and why aren't you getting ready for church? Oh, I'm sorry, I didn't realize it was Sunday. Well, how about if we have breakfast and then we'll get ready and we'll go to church. And then during breakfast, you're chit-chatting about other things, and hopefully they forget about going to church. So you just kind of get in their reality and move along those lines with them. Always remember the body language, because they read body language. Everybody reads body language, and we don't even realize we're doing it. Dogs are masters at reading body language. Cats, who knows what cats do? They're pretty smart, though, so they probably do too. But people with dementia rely much more on body language than spoken words.
So they know if you're angry.
They know if
angry,
you're frustrated. If you're uptight, if you're frustrated, they will know it, and they will mirror that. So always try to keep them in a happy place. It's much harder than that sounds, but the happier they are, the happier you are. So never take anything they say personally. Try to just let it roll off, because you know that if they were in their right mind, they wouldn't be saying or doing these things. So try not to take any of that personally.
An example of what you're talking about, my mother who has vascular dementia as a result of stroke. I went to her house a couple of weeks ago, and she was telling me she lives on, she has a 2-story house, but her bedroom is on the 1st floor, and she lives at home with 24/7 care. And she told me, Patty, I slept upstairs in a beautiful brass bed, and she was telling me about how wonderful it was. And I could have said, oh, well, you didn't sleep upstairs, you can't walk. But I said, there's nothing better than a great night's sleep. Mm-hmm. And so, yes, she had this fantasy, this hallucination, and for her, as you said, it was as real as I was standing in front of her.
Yes. And so you just go along with it, and you enjoy it with her.
Right.
And you both get a smile out of it.
So we go now to Jacob, who is calling us from Clearfield. Go ahead, please, Jacob.
Hello. My wife has had dementia and Alzheimer's for probably about 12 years now, maybe longer. But I noticed when a nurse mentioned paranoia, she was diagnosed as dementia years ago, and that was explained like an umbrella, and then all these different things come down from the umbrella, like Alzheimer's, St. John's, and various illnesses, you might say. But what we noticed early stages, I lived with her alone. My children were all raised, and we lived alone, just her and me. And what I noticed at the very early stages, she couldn't button her shirt correctly. She'd get the buttons in the wrong holes, her jacket or any shirt, anything that had to be buttoned. And same with the slacks. If she went to put slacks on, she'd get the two legs into one leg. She'd get her two feet into one leg. She couldn't dress properly by herself. She had to have some help. That was the first stages that I noticed that she was having something going wrong. And then, of course, she'd get frustrated. Her mother and dad both wound up in a home with Alzheimer's. She had a brother and two sisters, and the whole family had wound up in the hospitals with Alzheimer's. And I never believed in genes that much, but in this case, everyone in the family, her brother died 10 years younger than her, and her sister's in a home right now, and she's younger. The whole family just, I couldn't understand how they got wiped out with the same disease. Now, here's an interesting statistic or fact, though. When she was in the dementia area, she's in with a lot of other patients, and they would, mingle, and they had activities for them. That's before they put her into a Alzheimer's room. But I kept her at home for about 7 years, and finally the nurses took her off of me because she needed medical attention.
Mm-hmm.
A lot of medical attention, and because she got very hostile. You couldn't change her diapers, for instance. Oh my goodness, you wouldn't realize how strong she'd get.
Right.
And washing her hands was a battle.
Thank you, Jacob, for your comments. Let's talk a little about the changes in behavior that Jacob was talking about there. Someone whose personality changed, and for instance, helping her with daily needs became a battle.
Yes, it's very common, unfortunately, and it's often the thing that makes families decide, I can't do this anymore. I have to place them in a facility because I just can't handle all of this daily. Every time I turn around, they're undressing again or something like that, or they refuse to allow me to bathe them, and they smell bad, and they really need a bath, and they refuse to eat, and I don't know what to do. So these are often things that precipitate a move into a facility. So it's very challenging, and the families really need to learn about the disease and learn ways to interact more appropriately with that loved one so that you don't have a lot of this negativity going on.
You said, for instance, if you can't get a loved one to drink, and hydration is important, sit down with them, and lots of people with Alzheimer's still, their social graces have been spared. So yeah. You can sit down with a tray and 2 glasses like you're having a tea party, and they'll want to sit and have a drink with you. But if you just handed someone with Alzheimer's a drink, and they don't even recognize that they're thirsty, even though they're obviously dehydrated.
Yeah. That's a great way to do it, is you don't ask them if they want something to drink, you just hand it to them. Or you say, would you like orange juice or would you like lemonade? You don't give them a lot of choices, you just give them 2 choices. And again, you sit down with them, you drink with them. Bathing is a huge battle oftentimes with family members, and you have to realize that if they won't go into the shower, if they won't take their clothes off, will they go into the shower with their clothes on? They'll be more willing to take them off once they're wet. And you can still get a wash up under the clothes with the soap if you have to.
And the bottom line is the thing that makes the caregiver's life in some ways easier, makes life with someone with dementia calmer, your household calmer, rolling with the punches, and
yeah. And so, if you're the caregiver of your elderly wife, and she has worn nylons her entire adult life, but now you struggle to put them on, and it takes you a half an hour to get those nylons on, well, just leave them off, especially if she doesn't really care. make your life easier.
We go now to Jean from Punxsutawney. Go ahead, please, Jean.
Hi. I have a twofold question. Well, first of all, my husband was diagnosed a couple years ago with Alzheimer's, and he's only 62. He was taking off and getting lost. I've had to have the police go after him, and they said I had to put him in the hospital, and from there he had to go straight to the nursing home because they said I wouldn't be able to take care of him. His speech now is getting garbled. I mean, I can't always understand him, and he gets frustrated with me, and he starts crying because he can't get across. Is this something that's ever going to get better?
Dr. Marsh?
If he has Alzheimer's disease, this will not get better. It typically gets worse with time. Now, what can improve, it would be sort of how things are going with the interaction, because he's obviously frustrated. And so I think the way that things can get better would be finding other ways to communicate. And sometimes that can be, finding, going along with him, trying to answer his questions for him, giving him other ways to try to communicate with you, not creating a frustrating situation, as Cindy was saying earlier. That can get better. And so the environment can improve even though the disease might be progressive.
I know sometimes with my mother, I act as though I understand exactly what she's saying. I brought dinner over the other night, and she wanted to add something to it, but I had no idea what the word was that she was saying. So I went to the refrigerator, and I said, how would you like to add strawberries to your meal? And it sort of distracted her from what she was after initially. Yeah. So, and reduces the frustration that our caller's talking about. Cindy, are there other
No,
strategies
I think,
that you can add to
Dr.
that?
Marsh was right on with that one. Maybe pictures, pointing at pictures of different faces to tell, if you're upset or happy or sad or in pain, that kind of a thing. Again, not asking questions that require a sentence for an answer. Asking the simple yes/no questions.
All right, we go to an email we have from a listener. What medications are used after a diagnosis? I understand that they may be helpful for just 1 year. Why would that be the case?
There are medications that have been developed that can help the symptoms of Alzheimer's disease. And there are several. Most of them are what we call cholinesterase inhibitors, which means it increases the amount of acetylcholine, which is something that these brain cells need, and something that tends to be lost in Alzheimer's disease. So it can improve. It can improve how the patient is functioning. It can improve a lot of the aspects of Alzheimer's disease. But what we typically see is that improvement, as you pointed out, is relatively short-lived, 8 to 12 months, and then the patient is often back to where they were before. So it doesn't provide a cure. It doesn't really prevent progression, but it may give an 8 to 12 month period where the progression is slowed, or maybe even held at bay for just a bit.
And are there other medicines on the horizon in terms of treating Alzheimer's?
There are other medicines that are being tested. In fact, there are a lot of tests that have occurred looking for that wonderful medication that might treat Alzheimer's in the way that, for instance, we're successful in treating Parkinson's disease. But that medicine has not proven yet in clinical trials. The more promising research now is in how to prevent it, how to detect very early stages, people who are just beginning to have problems. That would be the most helpful type of therapy. And there are some interesting drugs that are being tested that would help prevent those deposits of protein and hopefully help prevent the progression of the disease. But they're all investigational, and none of those are proven to be effective yet.
In the absence of a cure, and a cure is a long way off, I think we would all acknowledge that, what can each of us do today, Cindy, to improve the lives of someone with Alzheimer's disease and their caregivers? And I'll ask the same thing of you, Dr. Marsh.
Caregiver support groups are crucial, and so many people are resistant to that. They don't like to go to groups. They don't like other people knowing their problems. Men especially would say to me, what do I want to go listen to a bunch of people talk about their problems for? I have enough problems of my own. Well, that's true. They do go and they talk about their problems, but what you find is that, my wife was having that problem, and this is what we did, and it worked really well. You get so many tips to help you with your own caregiving. And not only that, but misery loves company is really true. You find that when you're with this group of people who are going through the exact same thing that you are, or worse, that you feel that camaraderie, you feel that support.
Dr. Marsh?
I would agree with that, and I would also add that I've seen, in a husband-wife situation, I've seen them to be able to maintain that connection that's kept them together for so many years, that love, and find new ways to connect with each other, and that seems to keep them happy as a couple and seems to benefit both the caregiver and the patient.
All right. Thank you both very much. Our guest today, Cindy Keith. She's a nurse and a dementia professional, and Dr. Marsh, a neurologist and professor from Penn State. We hope you will join us in February when our topic will be criminal justice system and mental health. For all of us here at WPSU, I'm Patty Satalia. Thanks for joining us, and good night.